Good morning, everybody, and thank you for joining us in a chilly morning, at least in Philadelphia region. Welcome to the Global Neurosciences Institute Grand Rounds. There are several housekeeping announcements I have to make before introducing today's speaker. Our Grand Round series is a CME granting activity, and you should use each system to claim your CME certificates. If you have any questions or difficulty with the system, please contact Nicole Myers. If you have a question for today's speaker, please use question and answer feature. The speaker will be asked those questions after this presentation. And now it is my great pleasure to introduce today's speaker, Dr. Oleg Teytelboym. Dr. Teytelboym began his academic path by earning an undergraduate degree in physics at Rutgers University, followed by completing medical school at the University of Michigan. He pursued a radiology residency and fellowship at Johns Hopkins, where he continued as a faculty member. Seeking new opportunities, he made the decision to relocate to Philadelphia area, joining Mercer Fitzgerald Hospital as a program director of radiology residency. He eventually assumed the role of chair of the radiology department at the same institution. In addition to his clinical and academic responsibilities, he serves as a designated institutional official overseeing graduate medical education at Mercer Fitzgerald Hospital and holds a position of chair of Trinity Health Mid-Atlantic Institutional Review Board. Throughout his career, he has garnered recognition for his contributions, including the Radiology Society of North America Honored Educator Award, the Silver Medal for the American Rangan Ray Society, and the Most Downloaded Paper Award bestowed by the European Society of Radiology. Dr. Teytelboym will be talking today about multiparametric glioma imaging. Dr. Teytelboym.
Well, good morning, and thank you very much for the kind introduction. All right. So let me share my slides and get started. This morning started with our Epic system crashing countrywide, but the backup system's working, but everyone forgot how to click on a backup system. So we've been running around all morning teaching people how to click the button. All right, so hopefully no one's going to barge into my office and everything should be set up. All right, so let's see, which button do I click here? Okay, this should work. Okay, so this slide should advance. All right, so no disclosures, but I'm obviously open for bribery just in case. Okay, so today we'll talk quickly about glioma classification and the imaging phenotype, just quick refresh of the updated guidelines. And then we'll switch over to modern concepts of parametric imaging, obviously highlight the typical sequences such as enhancement and flare, specifically focus on diffusion, perfusion, spectroscopy, and some of the novel techniques that are coming over the horizon. And we'll just quickly talk a little bit about the AI applications that are coming up. Okay, so first pitch is, this is a recent case from our own health system, and I read both of these. The images at the bottom is just a standard evening scan out of the emergency department. There's something, let's do an MRI and give contrast. And this is 1.5 Tesla. You can see that you obviously see the lesion, you see it's enhancing, but then the next morning, of course, we brought the patient back for a tumor protocol scan on 3T. And honestly, this is night and day, and both are modern scanners, top of the line 1.5 and top of the line 3T, but you can't even compare. If you look at these, especially in the post-contrast images, it's almost as if these are very different patients, and you just can't. And of course, if you look at the corpus callosum, you can clearly see that the tumor is crossing layers, and the 1.5T don't know. So very, very important. Have to know your scanners and have to use the right protocols. Next, before talking about the glioma, every talk always starts with updated system. And the most recent revision has been really excited because we're switching from just histologic classifications of tumors to genetic-based differentiation. And that's obviously something that everybody's aware of. And we're separating, broadly speaking, tumors into the IDH mutant and IDH wild type. We can't predict this histologically, although we can't predict the histology or the genetics, looking at the images, although sometimes we can guess. So at the end of the day, every tumor needs to be assessed with tissue and molecular and genetic analysis. But understanding of the genetic profile, understanding of the imaging profile, all blends together. And as the time goes by, there's going to be ever increasing integration and understanding. So we are in radiology world trying to switch folks to using the correct terminology and getting used to it. And one of the interesting tips, you can always figure out when somebody created their slides. So in the modern system, the grading of the tumor is Arabic numerals, but every other system before that was Roman. So if you see people talk about grade of glioma using Roman numerals, these slides are outdated and were created before the latest update. So, and obviously everybody here is aware of the key mutations such as IDH and 1p19q co-deletion that separates IDH mutant astrocytoma from oligodendrogliomas. And in cases of a GBM, the tumor has to be IDH wild type, as well as show either additional mutations such as EGFR amplification, or histologically show necrosis. And with the necrosis, we can see pretty easily on MRI. Okay, so just to quickly run through the standard morphologic classifications as they're published and known to everybody. This is a typical look of a GBM or IDH wild type tumor with necrosis. So you see this ring-enhancing lesion with thick irregular contrast, central necrosis, and you see high surrounding signal and flare, which represents combination of tumor cells, reaction to tumor, and often is a blend. And it's often nearly impossible to tell where tumor starts and where it begins, but this is a combination of tumor cells and edema related to tumor. And this is diffusion where GBMs typically do not have a lot of restricted diffusions, but we'll talk more about this. Now, this is an example of a tumor that we would never guess that this is a GBM. We see high flare signal, looks reasonably well circumscribed, no enhancement, no increased blood volume on perfusion, but on the molecular analysis, this is an IDH wild type GBM with EGFR amplifications. And so imaging is decent, but not 100%. This is another set of another 3 patients with examples where you can see again varying appearances in T2. This one is there's a little bit of infiltration, but none of them enhancing. And these are IDH wild type GBMs with TERT mutations. Now, this is a prototypical look of an IDH mutant astrocytoma. This is the typical T2 bright, flare dark, so T2 flare mismatch that's supposed to have about 97% accuracy, and the tumor is not enhancing. And if we see this, we can be reasonably sure that we're dealing with an IDH mutant astrocytoma, typically grade 2. And as these lesions migrate towards high grades, such as grade 4, that tend to enhance. So this is an IDH mutant astrocytoma, well circumscribed on flare, but it is enhancing, so that's much more typical for grade 4 lesions. This is a typical look for oligodendroglioma, or as we should be calling this IDH mutant 1p19q co-deleted tumor, where we see dense calcifications, enhancement. Although interestingly, in our regional tumor board, a recent case that looked exactly like this ended up being a GBM of the very typical morphology. So, but predominantly dense calcifications, enhancing tumors, these will be oligodendrogliomas. So GBM and gliomas are one of the most interesting areas of radiology, exactly because things are so confusing. And that's why I personally have gotten ever more interesting, because we're really trying to differentiate enhancing tumor from non-enhancing tumor and from variety of tumor reaction and post-treatment changes. So not only we take the normal brain and we injure it by tumor, but we also surgerize it, radiate it, give it adjuvant, chemotherapy, immunotherapy. So separating what's what becomes very difficult, but the more difficult it is, the more fun it is. So when we talk about imaging of GBM, we always try to find the magic answer, be it perfusion, be it spectroscopy, be it diffusion, but it never quite works that way. It really requires a multiparametric approach, meaning we have to look at a variety of parameters and use them together, and I will show you some examples why this has to be done. So Enhancement is the breakdown of blood-brain barrier. T2 is just intrinsic characteristics and tissue reactions. We can find hemorrhage very accurately, preferable using susceptibility images. If for people that don't, they can use gradient. Cellularity density, this is with the diffusion. We can assess neovascularity or perfusion of the tumor by estimating its cerebral blood volume. And finally, we can use molecular characteristics. And AI blends this naturally. As humans, we sort of do the same thing, but we really have to look at every single technique together to come up with the right answer, and sometimes we still can't. So we'll start by diffusion imaging of brain tumors. Most typically, all of us used to using diffusion to diagnose infarct, maybe an abscess, but in reality, it's not restricted. Now, in most GBMs, it actually doesn't work super well because tumor has a significant overlap with cortex, edema, gray matter, white matter, and this is a really nice example. And even using variety of diffusion weightings doesn't help, but that's not always true. There are certain subsets of tumors that tend to stand out, and this is where the diffusion can be life-saving. But diffusion is really focuses, it's not just an infarct, it's not just dense cellular extracellular matrix. When tumors get packed, when tumor cells get packed, the diffusion gets restricted. This is an example comparing a tumor that's a grade 3 and a grade 4. We can see grade 4 has enhancement. And if you look at the tumors that are grade 4, the distribution of ADC is the quantification of diffusion, diffusivity. The lower the number, the more restricted the diffusion. You can see that it trends down, and if you compare how the images look, certainly Ki67, so proliferation will correlate nicely with decreasing ADC and presence of restricted diffusion. And the next questions that people have asked: can we separate the grades of the tumor if we use really, really high B values? And B value is a measure of how we're the higher the B value, the more we're able to separate the signal between diffusion restriction and the normal tissue. Typically in brain, for stroke, we use 800, 2000 as the maximum. In tumor detection, we try to push it higher to 1500, sometimes 2000, 3000. Those images tend to be very difficult to get, require advanced machines. But even by using that, still a hard time separating low grade, high grade. But again, that's not necessarily true for all of the subsets. And this is an example of how things can help. Again, this is a recent case from our institution. It's always nice to illustrate the points of looking at recent cases. So this is a scan out of the emergency department. We're seeing a tumor that looks fairly dense in periventricular location. And on the coronal images, you can sort of see that it seems to be sneaking towards the corpus callosum. It just looks a little bit dense on the left side. So, well, looking at this, even in the CT, we can suggest that this is either GBM or lymphoma. Typical location for either increased density. So which one is it? The density is 38 Hounsfield units. So, and you can see that it looks same as cortex. CT scan's pretty good. You can see gray-white differentiation pretty nicely, at least on my screen. I hope it when the images get streamed, that gets translated. So this is where we can use diffusion, and this is where it can be extremely helpful. So if you look at some of the data, and it's amazing in the radiology world, a lot of high quality research actually comes out of South Korea. There's something about different countries' preference. Let's say in endocrine world, I understand Italy leads the pack, but in radiology, in addition to the United States, I always seem to refer to Korean published papers. You know, Germans produce by far the best pictures, but somehow there's just something special about the radiology community in South Korea. So if you look at the data of GBMs and CNS lymphomas, what they show is if you look at the CT density, So most primary CNS lymphomas tend to be pretty dense, live around 40 Hounsfield units. Now, GBMs start there, but then they tend to drop down significantly, and the GBMs have a big range. But if we look at the ADC values, CNS lymphomas live below 1. Now, GBMs span that spectrum, but most of the GBMs live above 1. So if we really use 0.9 or 1 as a cutoff, that's a pretty good differentiator. And once we quantify diffusivity, you can see that the ADC value of this lesion is 1.1, and we can be fairly sure that this is a GBM. And we see if we plug in 38 Hounsfield units, this could be both, although just a tad bit less than the typical lymphoma. But for the ADC of 1.1, we're nowhere near the lymphoma, so this is GBM, and you can see that's not definitely not a very dense structure. So this is the ADC. And the histology, the tumor biopsy and the resection bore this out. So speaking about application of diffusion, so this is a very standard case that we get to see. A patient had the resection of a right temporal GBM. As always, there is some areas of high flare signal next to the resection cavity, reflecting gliosis, post-radiation changes, and that's a typical application that we get asked. And as we see, all right, there's nothing's enhancing, nothing's perfusing, just a little bit of a flare. Spectroscopy pattern is unremarkable. Choline and NAA about the same. ADC, nothing's happening, so we can be fairly sure that this is negative. But then the next follow-up, all of a sudden, we're seeing enhancement, we're seeing surrounding flare, we're seeing increased perfusion, we're seeing abnormal spectroscopy pattern. But what we're also seeing is restricted diffusion. So the tumor itself is bright on diffusion. It is low on ADC, so that's clearly restricted diffusion. So this enhancing component that's increasing perfusion, you can see it on diffusion sequences. And what we know from tumors everywhere in the body is that things you see on diffusion tend to have a really good differentiation between tumor and the background. So things you can see in diffusion, you can find very easily because it's not like a perfusion image where, vessels and everything has a ton of perfusion. So sometimes can be really hard to pick it up. Here you can see it easily, but depending where the dot is, could be really, really hard to find. So as we look through the rest of the brain, we see, okay, well, high up we see this dot on diffusion. So that dot on diffusion is a tumor because we do know that now the current tumor is restricted. When we look on flare, I mean, barely there is a dot, even though this is a 3D scan. Probably could have pushed the resolution lower and found it better, but I don't think I would have picked this up. On post contrast, there's just the faintest blush. Again, would have missed it. This is the perfusion scan for sure, right? There's clearly increased perfusion there, but what's the chance of us picking this dot up? Like 0. De novo, maybe AI would have, but probably not. Again, spectroscopy is abnormal. But really, the only reason we're finding this is that the lesion has restricted diffusion. So we tend to look at this on every case, and if the tumor has restricted diffusion, really helps to pick up disease elsewhere and find it in the background. So things that restrict tend to be really easy to find. All right, so next we'll switch to one of my favorite topics, perfusion of brain tumors. And this can be done in a million different ways. Everybody has their preference. Virtually everyone who does it clinically tends to use dynamic susceptibility contrast. And what you are relying is on the gadolinium molecules coming into your field of view and then causing artifact. And based on that artifact, you identifying how much gadolinium, and you can calculate the numbers. And the typical parameters, you calculate cerebral blood volume, cerebral blood flow, transit time, time to peak, and you can create the curves. There are other techniques. You can actually use dynamic contrast enhancement. where this is a little bit more of an advanced technique. People really use it in research, not clinically, where you can calculate and quantify things even better. And this is where you hear the K-trans. For a while, arterial spinal labeling was super popular. Still in pediatric world, it is very, very popular, where you don't even use any contrast at all. You label the flow using manipulations of the magnetic field, and then you're able to detect it. Now, arterial spin label images are characterized by being the most useless, and they really don't look pretty. So ASL was really popular during a few gap years. As I still remember the days before we recognized NSF existence. Then we suddenly woke up, and everybody was scared to use contrast, especially in kids, and then people were using ASL. Now, over the last half a decade or the last decade, we have the modern agents where gadolinium molecule has several chemical bonds to the carrier molecule, so it doesn't differentiate, it doesn't deposit in the brain, it doesn't cause NSF. Specifically, dodoram was the first one. Now there's a few analogs, and you don't need to worry about renal function at all. Just use it, which is what we do. And so ASL it doesn't look as good, so it's much less exciting. So we've switched, everybody switched back for the most part to dynamic susceptibility contrast. And this is what it looks like. Usually CB, cerebral blood flow and cerebral blood volume are the best looking pictures, just because there is a lot more data. And then time to peak mean transit time is usually not as pretty on the MR. And this is what we're calculating. The cerebral blood volume is the area under the curve, and cerebral blood flow is the derivative or the shape, and everything else is single time points, and you can see how the picture is. In brain tumors, we're really just interested in cerebral blood volume. Certainly for stroke patients, there's a lot more parameters, but for tumor cerebral blood volume, the area of the curve, and this primarily represents neovascularity of the tumor. Sorry, people keep calling me, I guess, trying to figure out where the backup button is. All right, so mostly neovascularity, unlike contrast enhancement, which is capillary relief. Let's see. All right, so this is another recent case in our health system, and this is, again, very typical looking GBM, avidly enhancing irregular thick enhancement, surrounding high FLAIR signal, representing combination of tumor infiltration and edema, not much in diffusion, bright on T2, and this undergoes gross total resection. And you can see this looks amazingly well. The enhancing component of the tumor is out, and gross total resection looks remarkably good. And this is an image right after the resection, and we all know that the ideal time to image tumor after gross total resection is within 48 hours, so you don't develop granulation tissue, and you can establish a new baseline for what's tumor, what's post-operative change. Really helps to interpret the subsequent follow-up MRI. So after surgery, brain MR within 48 hours, preferably 24 hours, is profoundly helpful. But at the same time, as we look at this patient, we see there's a whole bunch of FLAIR bright dots. Now, this is not a young patient, so you can expect some white matter disease. And these dots are typical chronic small vessel ischemic changes. But there's a dot here on the right side that's just a little bit bigger than you see. So you really wonder, and the typical discussion historically would be, well, the tumor's close to the corpus callosum, but it's not crossing it. So just, let it be, doesn't enhance, probably nothing. But so let's see what happens. Within 3 months, as often we see in these patients, the patient develops a recurrence. So we see an avidly enhancing tumor above the original surgical bed. There was nothing there on the original scan. You see that there's increased cerebral blood volume, so there is neovascularity, a typical pattern of FLAIR. Diffusion, it's really not significantly restricting. Spectroscopy pattern, very typical for GBM. Really high lactate lipid peak. NAA peak is nowhere to be found, so all neurons are gone. And we just see some ischemia and necrosis. So definitely recurrence, not post-radiation change. This is perfusion in the typical spectral pattern. Now, when we look at that, so now that we're imaging the patient in an advanced magnet with advanced techniques, if we look at that area of high flare signal, well, that is now transforming. So still no enhancement, but it does have increased perfusion, so there is neovascularity. And spectroscopy pattern doesn't look quite normal, although not nearly as bad as the recurrent lesion. And then if we look at the diffusion, there is actually mild diffusion restriction. So it is really bright on B1000 image. And on ADC, it's not as bright, so it's not just a shine through. So suddenly this area is developing mild diffusion restrictivity. So again, combination of all of these diffusion images can really, really help us, but all of this has to be interpreted in the context. So certainly in this case, I think what clinches it is the perfusion, but all of it together is very, very helpful. All right. So now looking at the tumor response, and originally tumor response has been one of my personal biggest interests, as all of the guidelines have changed. And this is really difficult to calculate, and it's really complicated, and nobody wants to deal with it, so it becomes more fun. And no, this is nowhere more true than in the GBM model with pseudo-response, pseudo-progression, and traditional approach to that. And let's say if you ask somebody from a place like Mass General that does a lot of these, their response is, well, we don't bother with any of the modern sequences. For the most part, we just image the patient like every few weeks, so once a month, and then we'll find out what happens. But there is a strong interest in trying to estimate the response early. So what we see by using advanced techniques without going to the depth of the actual response criteria is this concept of match and mismatch between enhancement and perfusion. So a lesion that's enhancing but does not have increased perfusion is usually not tumor, because enhancement is leaky capillaries, and capillaries can leak from any cause. Tumor can leak, post-radiation change can leak, chemo can cause that, and so enhancement is leaky capillaries, but perfusion is neovascularity. So this is a really nice example where this is a tumor post-op. There's a little bit of signal there. 6 weeks after chemoradiation, suddenly there's a ton of enhancement, but perfusion is decreased. So this should be called, so this is not a real tumor. And then the subsequent follow-up, the enhancement goes away. So increasing enhancement without increasing perfusion is post-treatment change. This is an example of a progression where this is a post-op tumor where now we see in the left frontal region, we see development of enhancement that's now matched with increased cerebral blood volume or neovascularity. And then the follow-up scan, we can see that this is increasing, as opposed to the parietal enhancement, which turns out to be nothing, and there is no increased perfusion. So again, matched enhancement with increased perfusion is a predictor of tumor. So that's a neovascularity. Another example of pseudoprogression, where we see development of enhancement without matched increase in perfusion. There's just a single dot, but dot is not much of anything. And then on the subsequent follow-up, we can see enhancement is going away, and again, there is no perfusion there. Now, of course, patients don't do great. So even though the right frontal was treatment changes, there's a tumor in the on the left parietal where we see development of enhancement with the matching perfusion. So the patients will still do poorly. All right, so hopefully I'm not running too quickly, but let's talk a little bit about the spectroscopy. And then we can start looking at some of the examples of how the images work together now that we will review all three major modalities. And even before this, I kept showing all images of uh, emphasizing this concept of multiparametric. Hopefully, by the time I'm done with the spectroscopy, everybody's online will have a reasonably good idea how to interpret these images, making it easy. All right. So normal spectral pattern. I really it gets a little bit complicated, but the metabolites I want everyone to know is NAA. And NAA is traditionally a marker of normal intact neurons. So if you see high NAA, the neurons are alive. So this should be by far the highest peak, 2 parts per million. So you see this peak, that's normal. Peaks to the right of it, this is lipid lactate. They really should be essentially non-existent. And this is marker of ischemia and necrosis. So lactate obviously speaks for itself. And lipid is when the brain tissue dies, we tend to see lipid show up. And then other metabolites, creatinine is usually considered the baseline. So unless everything's dead, things will revolve around the creatinine. And then choline, and choline is a marker of cellular metabolism and cellular membranes. So choline and creatinine should be roughly the same. Both should be way below the NAA. And if things start to proliferate, the choline peaks will go up, and you can use the height of the creatinine peak as a baseline. And we'll briefly talk about myoinositol. So in meningioma, we really should not be seeing any NAA peaks. We can see some characteristic alanine peaks. In metastases, we just tend to see necrosis. Again, we shouldn't see any NAA peaks in there. And then as we look at the gliomas, a lower grade neoplasms will just manifest with a suppression of NAA peak, and then elevation of the choline peak. As this progresses, choline will go higher, NAA will go lower. And then once we get to GBM and the necrotic pattern, really everything disappears, and we tend to see really high lipid and lactate peaks. We can differentiate that using different weighting, but that's typically not that important. So we just look at the peaks here. So this is a pretty good illustration of what we're going to encounter. So we can look at some of the primary examples. So again, NAA, intact neurons, choline and cellular membranes. Creatinine is a brain-independent baseline that's really helpful, and lipid lactate is markers of ischemia. Going back to the patient we showed you in the very up front, so we see obviously bright T2, bright flare signal, avid enhancement, increased perfusion. Now, we're adding susceptibility images. I'm not going to go say too much about them. That's a whole universe. But this really helps us identify hemorrhage. Oxygenated blood has paired electrons. All of the forms of deoxygenated blood have unpaired electrons, and as such will be paramagnetic, and we can identify them so that we can see there's bleeding in the tumor itself. And that's what's one of the reasons the spectroscopy pattern looks so weird. There's a lot more artifact in it. Now, as we look around in this lesion, it is crossing the midline, so that's not great. But we do see a few flare bright spots contralaterally. We see one above the tumor. So, well, is this tumor? Is this small vessel changes? What's tumor? What's not tumor? This is where things get really complicated, and we're trying our best to help the surgeon, radiation oncologist, neuro-oncologist, neurologist to navigate these cases. So is everything bright tumor, or is everything bright not tumor? And if we look on the right side, we see that this area that's bright on flare really looks like just a hole in susceptibility, ADC. Really, there is not even a hint of the increased perfusion. And if we look at the spectroscopy of the lesion, we see that Well, choline and creatinine about the same. That's exactly what it should be. But most importantly, we see high NAA peak. So even though that there is ischemic changes there and we see this gliosis, the area shows the intact neuron, so we can be pretty sure that this is just chronic changes. Whereas the lesion adjacent to the tumor on the same side, although we're not seeing increased perfusion, the spectroscopy pattern of that area, I would just use a very scientific term, looks weird, but that weird is looking very similar to the tumor. So the chances are this is a tumor, which sort of makes sense because it's right above the original tumor. Now, is all of this perfect? Not always, and this is a case I want to show and share where the concept of multiparametric imaging becomes ever more interesting. And this is a very recent case where we looked at it, we thought we knew what we were doing, and then made us scratch our head a little bit. So we're seeing a lesion here, enhancement, lots of flare around it. When we look at it, there is a susceptibility, so there is some blood products along the rim. The rim is just really basically fluid. The internal contents are crazy restricted diffusion. This is a B1000, so incredibly bright. This is ADC. This confirms it. We actually had a CT perfusion. Not typically what we use for tumors, but still, in theory, should be the same. We see there's really no perfusion inside the lesion. So we did. We also had a single spectroscopy from the lesion itself, where we see, well, this is just lipid lactate, and there is nothing else in there. So is this tumor? Is this abscess? Is this something else? At the end of the day, looking at all of this, we said, okay, well, we're just going to trust the diffusion because this is the brightest thing ever. So it's, glioma is never restricted much. So this has to be an abscess. Patient had some risk factors, but not really appropriate. And we'll just say because this has restricted diffusion so much, it has to be diffusion as the magic bullet. Maybe we'll just sort of ignore the way it looks in enhancement, partially squint at this, and we'll come up with the answer. So it has to be an abscess. Well, turns out on surgical intervention, this turned out to be GBM. And even looking back at it, puzzling, this is a typical look for an abscess where we see lipid lactate, but we also see a variety of metabolites. When I went back and looked at my literature, it turns out this specific pattern is only about 80% of the abscesses. 20% really don't. So even if I go back to the original sequences, in the literature, people do publish abscesses with only lipid lactate peaks, as we saw here. So I'd probably call this an abscess again, maybe not looking at the rim. Wonder if AI will do better. So at the end of the day, if our accuracy is in the 90s, that's pretty good. But still, maybe 1 out of 10 patients, we're not going to be right just because the tumor will do what the tumor wants to do, which does make our life is much more interesting. But that's why there is no replacement for a surgeon. There's no AI replacement for biopsy. At the end of the day, tissue lesions still need to come out, still need to be tissue. And this is one of the examples where even in multiparametric imaging, we can confuse ourselves. And even in retrospect, I don't know I would have said anything else different, just because. All right. This is another case, again, very recent, that's really interesting. So it's a left paraventricular lesion, high flare, high T2, really not a lot of volume loss, young patient. So looked at this, we said, okay, well, it's got to be a glioma. Then we start to do the scan. We see these areas in the lesion. Well, it's bright on T2, dark on flare. Is this really T2 flare mismatch? We're going to be able to diagnose grade 2 IDH mutant astrocytoma. Then post, not even a hint of enhancement, then looking at the perfusion. Well, these areas that are bright on T2, it's not even just, nothing. It's like a hole similar to the ventricle. So that's not looking like a tumor. So maybe this is just cystic encephalomalacia, and that's why it's suppressing. We still get our DTI images. We finally figured out how to get our magnet to cooperate, and instead of these 3D maps, create cryptography that you can scroll through as a regular sequence. We're happy with that. And then we start doing the spectroscopy, and then I'm looking at this, I'm like, what is going on? I'm actually seeing, you can't see it on the screen, but this is my ionositol peak. You can have a little bit in like a low-grade astrocytomas, but the highest peak here is myoinositol. It's not like NA is gone. Cholin's a little high, but not crazy high. But myoinositol, what on earth? So after scratching my head and tearing out the rest of my hair, well, at least now I have a beard, so I can work on that. I remember a few recent articles of people publishing whole brain spectroscopy in patients with MS. And what they described is actually the myoinositol to NAA ratio is the most sensitive factor for detecting active MS lesions, better than everything else. So with a really high quality magnet, it seems that myoinositol detection is the way to go for MS. I'm like, but I wasn't expecting to find it. I was expecting to find a glioma. But again, number of articles really demonstrating that, and this is something I remembered reading from the year before, showcasing some of the 7 Tesla images of beautiful spectra where you can see this myoinositol peaks. All right, so armed with that, then we start really carefully, which we would have done anyway, looking at the rest of the brain, and we find a lesion in the juxtacortical lesion in the frontal lobe that's involving the touching, involving the cortex, where it is enhancing, it is bright on T2 and flare, and is restricting on diffusion. It wasn't there before, or maybe the magnet didn't have enough Tesla to detect it, so that all fits beautifully now. So I have an elevated myoinositol to NAA ratio. Now I have other lesions that fit the demyelinating disease pattern. So then all of a sudden, I'm pretty convinced that this is not a glioma. This is actually MS, and what we're seeing is an all tumefactive lesions with just cystic encephalomalacia, which really fits the perfusion pattern. And with this lesion, I think my pretest probability is super, super high. And to me, that was a joy. And when I texted the referring neurologist and the neurosurgeon, I was very excited. So this patient doesn't need a biopsy, but this is vastly more treatable than an astrocytoma. Okay, so let's make a slight left or right turn and talk about injuring the brain. So we really like to injure the brain with radiation and chemotherapy, immunotherapy. So how is that going to change our chemical composition? And of course it does. So this is the typical pattern that we should see. Pre-radiation, colon creatinine, roughly the same. NAA should be the highest. Once we radiate the brain, this is what we tend to see. This was a really nice paper where they looked at the patients right after radiation with just some normal volunteers. And we see the creatinine as the baseline, but the colon goes down and NAA goes down. So both of these peaks will go down immediately after radiation. So neurons are injured, cellular membranes are injured. Now, 6 months after radiation, we do expect to see some recovery. So colon will go up, and this is a normal brain. Creatinine should remain our baseline. NAA recovers, but not as much. So you see pre-radiation NAA is higher, post-radiation. This all generally looks about the same, and we'll show you a few examples. If you look at the ratios will oscillate. So nothing, so you really need to understand where we are to see exactly where we are, and this does have an impact on the cutoffs. So this is one of the seminal articles from now nearly 2 decades ago that set out some of the cutoffs, where they looked at the tumor post-radiation, tumor recurrence, the cases that were proven. And what they said, well, if you look at the ratio of colon to creatinine, colon to NAA, NAA to creatinine, really Choline to creatinine and choline NAA tends to be the best. And for the tumor, choline to NAA was averaging 3.5. Radiation injury was 1.3, and the normal white matter was 0.8. So that's a pretty big difference. But still, you can see that choline to NAA ratio was dropping to 1.7 when it was overlapping with some of them. So the cutoff ratio they suggested was 1.8. Now, it is important to realize the magnets are better. The sample was not the huge, and this was early work, so that ratio is 1.8 is not the 11th commandment or the 0th commandment, but it's a really good guidance as long as we understand how that number was calculated. And there is still going to be some overlap that this number is pretty reasonable. So people use the choline to creatinine and choline to NAA. Now, often when I talk to people in the field, everybody has their preference, right? You know, BMW is better than Mercedes or Tesla, vice versa. So people prefer perfusion, people prefer choline to creatinine, people prefer choline to NAA, and for good reasons. But this is a really neat meta-analysis. So the conclusion of meta-analysis was actually that choline to creatinine on paper is the best. So in theory, this is a differentiation, necrosis versus recurrent tumor. And if you look at the average, you want to be as far from this baseline as possible. The average on choline to creatinine was the furthest away. But still, like in a couple of trials, your range overlapped. In perfusion, actually, none of the trials overlapped, although you weren't, you know, the average was a little bit closer. And then in choline to NAA, again, pretty good, but in a couple of trials, there was overlap. So theoretically, the best differentiation is choline to creatinine, but in none of the trials, perfusion overlapped. And their suggestion was just to use this. But to me, that just says you have to use all of it. Again, this is multiparametric imaging. There's no magic bullet. In theory and paper, this is the best, but CBF should always work. Or CBV should always work. So take your pick. So it's not one, it's all of the above. Okay. Let me show you another case illustrating these concepts. This is a right temporal GBM. Surgeon does an amazing job. The lesion's taken out. And again, typical question, what is this flare signal around the resection cavity? Is this tumor? Is this not tumor? And so we do multiparametric imaging. And we'll look at this. There's no enhancement in the area of a high flare signal. There's no diffusion restricted. CB perfusion's not up. And then when we look at the spectroscopy pattern, we see, well, this is choline, creatinine, NAA, they're roughly about the same. Now, I am showing susceptibility images intentionally. I find it extraordinarily helpful. In a lot of these areas of gliosis after radiation, we find some microhemorrhages, especially as the time comes by. You won't see them even on gradient, but if you do run susceptibility at 3T, you will see these dots. So if I see this flare with a few dots of hemorrhage, I'm like, okay, that's going to be just gliosis and usually bears out. But you have to look at all of them together and it helps. So what I want to show you in this case is this is progressively imaging closer to the resection cavity, further away. So you can see that this is a creatinine, choline, and NAA. So if you look at it, NAA is below these two peaks. You just move a little bit away. Now NAA is just as high as this peak. So you move a little bit further away. You still have the high flare signal, but now NAA is higher. And so the further away you move, you see that there is less damage to the tissue, less gliosis. So NAA becomes higher. This is a really nice illustration of a post-radiation. And depending how close we are to the resection cavity, we can integrate. Now, again, obviously, in theory, if this NAA was a little bit further down, choline was a little bit higher up, you'd say, okay, this is recurrent. So you have to integrate and understand that the ratio will change a little bit depending on how close you are and where the radiation field was here. But all of these ratios are well below the 1.8, so we can confidently say that this is just post-radiation. Okay, this is example of a MET that was status post-stereotactic radiosurgery. Again, we're seeing lots of edema. We're seeing enhancement around it, leaky capillaries. On the perfusion, In the lesion itself, we don't see anything. This turned out to be the normal gray matter that was slightly displaced. And when we look at the spectroscopy pattern, we just see lipid lactate. So all we see is just ischemia and necrosis there. So this is actually successful. So got to be careful. Easy to call this rim, but actually correlating with the images, this was just the displaced cell site, gyro. All right. So again, radiation injury, NAA slightly down, radiation necrosis, NAA is gone, everything's gone. We just see the lipid lactate. All right. I am almost out of time, but I think we're almost at the end, so I'll just show a few examples. Again, this is a recent case, oligodendroglioma resection 12 years ago, becoming symptomatic, clearly recurring tumor, and this is an example of spectroscopy analysis. So you see, this is one of the margins of the tumor. I'm not showing everything else, but this is definitely tumor. But if you look at the spectral pattern, this is the choline, this is NAA. The ratio is 2, well above the threshold, so we know that this is tumor. Again, creatinine is our baseline or the pivot. Now, another area, again, tumor, got to be tumor. So here, the choline to NAA ratio is 1.6. So in isolation, if we just say, well, we're just going to quantify, we know that 1.8 is the 11th commandment, and it's always true. But we use multiparametric imaging. Depending how we sample it, we could include a little bit of a normal brain or other areas. So here, I'm pretty sure that this is just a mix of gliosis and tumor. And the way it comes out in this specific ROI, that ratio is 1.6. I'm still, given all of the other sequences, convinced that this is tumor as well. Now, as we look medially, and it just looks palpably different. Now, we suddenly see that choline and creatinine are the same. NAA is higher, but somewhat depressed. Ratio 0.7, so this is just clearly gliosis. So in this area, I'm very confident that this is gliosis. Can we exclude one tumor cell? No, we can't, but this is gliosis. This is a mix of tumor and gliosis, and this is tumor. And you can see how the spectroscopy pattern is changing. So if we just took this image, said this is truth, well, not quite. Again, this is why the concept is multiparametric. Everything infiltrates. You always have a mix of changes, and it just has to be used rationally. Again, for radiologists, this is why this is fun. Some future directions. This is an article that was published earlier this year by a group from Miami. It was very interesting. So they started clinically using whole brain spectroscopy for radiation planning. This is their slides. So this is a resection cavity. You see sort of this questionable faint enhancement at the edges, so maybe tumor. They're doing a map of a choline to NAA ratio, identifying areas where that ratio is above 2, and adding that to the radiation planning. And this is what they reported is volumes. If they just planned based on enhancement, this would be the volume. Flares, obviously, everything's bright, so that would be crazy high. And you can see that the volume that they're treating based on the choline to NAA ratio of 2 is noticeably higher than the volume that they're treating based on enhancement, or even the volume they're treating based on perfusion of the blood volume, much better than ADC. So it's not randomized, but sort of they just did a case series illustrating this approach. Very, very interesting. Very technically demanding. So this is one of the very few publications, again, fresh off the press this year. This is a set of amazing images from Germany. They're using one of the new 7 Tesla magnets, where they're publishing amazing spectroscopy patterns, 3D maps of metabolites in a tumor at 7 Tesla. So they're actually creating volumes of different metabolites. This is, it's going to be a while before this becomes reproducible. I'm guessing even they have trouble because some of the images they published look god-awful, if that's their best. And they're illustrating that something's not enhancing, but if you're looking at the choline NAA, clearly there are other areas that are not appreciated just by leaky calculus. I wonder if we would have picked it up on other sequences. Very much possible, but again, these types of ratios is something for the future. This is AI, this is a hot area right now using machine learning, segmenting tumors, integrating it with a variety of histologic analysis, just analyzing the images itself, and coming up with additional data. So this is right now one of the most active areas. And you can see some examples using AI system to predict what tumors are going to occur, using AI symptoms to correlate with cellularity. I mean, in theory, we should be able to do this, which is based on the diffusion. This is a fancy way of grading it based on the AI. Now, again, Korean radiology research community. This is a very recent article. They're trying to look at a single enhancing lesion and differentiate GBM from a MET. And if you look at the performance of looking at accuracy, human readers, about 70%, 80%. If you look at the AI system, depending on if you're using combined mask, 90%. So in this specific data set, AI system performed better than either of the human readers and noticeably better than the traditional machine learning, where the humans were better or on par. Now the AI is performing better, differentiating GBM from a single MET. Again, this is early, not multi-institutional, obviously not a clinically validated, but no question in 5 years, this space for this is going to look very, very different. Okay, in conclusion, know your scanners. There's no magic sequences. Use everything together. All right.
Thank you very much. Thank you for walking us through this evaluation. And it sounds so easy when you explain this.
If I can do it, then everyone can do it.
So we have some questions for you. Okay, and the first question. First question is, where is the button for the Epic backup system? But so not related to the GBM, but do you have the ability to do MR vessel wall imaging and MR Nova?
Yes. So it's actually the simplest way is the same sequences we use in cardiac MR. We just run it in the brain. So we give contrast and then null the flowing contrast. So then whatever's enhances is the wall.
Okay. Can perfusion imaging be useful for prognostication of glioma patients?
I think there's certainly data and publications on all of these, but frankly, I don't think it's going to be nearly as good as genetic analysis. I think we've seen with the model, one of the reasons for the model reclassifications is you're finding these GBMs based on IDH status and then the AGFR that based on imaging just look completely benign. So I think it will always be vastly inferior to the molecular analysis. In combination, it seems to perform better, but not as the primary factor. I think if you take both, genetics will win.
Okay. Do you find that MR SPECT or perfusion is helpful in deciding what area to include in the radiation field beyond the flare changes?
I think this is definitely future. As you saw that study from Miami, this is what they're doing. There is a study based at Penn where they're designing option therapy based on whole brain spectroscopy. So I think this is clearly the way to go and should be incorporated. Perfusion is easy now. Whole brain spectroscopy is very, very difficult. We can't do it because it really requires very lengthy acquisitions and then IT processing capability to reconstruct. But that still doesn't mean you can't sample the worsening areas. So I think that really is the way the treatment is going to be designed in the future.
I think I'm going to add one more question. When just getting the scan, because all these multimodal imaging, usually we don't get it as a first scan, as a screening scan, or for whatever reason we're ordering, and frequently even contrast is not involved. So when we get these scans and you see these white matter lesions, which frequently are assumed to be vascular, are there any signs, is appearance or something that would raise a question, could it might not be vascular? Because, 70-year-olds, some, white matter changes, everybody's like, well, it's probably, chronic vascular, and everybody moves on, but some of them might not be vascular. So what would you suggest, in those kind of situations? Is there, anything for the practicing physicians?
So 10 years ago, everybody's answer was, well, we'll look at the follow-up scan and see what happens. I think now you really have to look at the perfusion, and you have to put a spectroscopy ROI on it. I think those two is really the way to go, and then obviously look at the other sequences. So on diffusion and susceptibility. So I think we should be able to tell reasonably accurately. And I think the key is if the dots are all same size, fine. We can just dismiss them. But once the dots get a little bit bigger and rounded, I start to really worry about them. And I think the spectroscopy then and perfusion becomes very, very helpful.
Okay. Dr. Teytelboym, thank you very much. It was a really great talk, and I'm getting all the positive feedback already. And for all the people who joined, I hope you're going to join us again in a couple of weeks for the next grand rounds. Thank you very much, and have a good Friday, everybody.
Thank you for the invite.